Welcome to the Future of Orthodontics. I want to congratulate you for being here seeking to perfect yourself in this beautiful profession. Dr. Kleber brought on the future a series of innovation that will change the way you see orthodontics. The event will start shortly, but first listen to the following instructions. First, have a notebook on hand to make your notes and save your doubts for the end of the class, where we will have a Q&A. For a better experience, I recommend watching on a desktop or notebook. The class will last an average of 2 hours. Book for a pleasant place and enjoy Dr. Kleber's generosity in sharing this knowledge for free. Are you ready? So send a greeting to Dr. Kleber in the chat to see him in 5, 4, 3, 2, 1.
Hello, you all. I'm laughing here because it's very interesting the way we're starting our class today. It's something new for me also. So hello, thanks a lot for being with me today. This is important to me. I've been teaching for a long time now, and since I've been in this field of teaching people from all over the world, I see that we are all together. We are all trying to make a better orthodontics in our practice, in our daily life. So for me, it's a great pleasure to be here today, to be in with you today with this new content in my way of teaching. And you see that during this presentation, I'm showing to you that some aspects are much more important than just technology. Although we have this beautiful technology in our hands, although we have this beautiful name of our practice, the future of orthodontics, I'm gonna prove to you, and you're gonna be with me in this thinking that the basics of orthodontics is the most important thing. So based on that, we are going to start the future of orthodontics. This is the first class. I need to tell you something now. You must be with us 3 days in this event, because the way I did this, the way I thought this to be, was like in the beginning of the process, I'm gonna show to you the way not to do things, the wrong way. The way I did in the beginning of my career, the way I was struggling a lot for changing, the way I was trying to, the way I pursued in my career for having a better way of treating orthodontics. So this is the first part. The second part will be based on the solutions that we can address for having a better orthodontic refinement, a faster treatment, and also a more refined outcome. And this is the way we do things. So in the third day, I'm going to give you some options and some practical way of thinking orthodontics. So be with us. Don't miss. It's very important, okay? And then we start now with this. The basics of orthodontics. Pay attention to the event schedule. Class 1, the main mistakes. This is something that you are going to recognize yourself in this. I've been there. I've been in your shoes before. So this is something that happened in my own life. I'm going to show to you how it happened. Cases that I was like struggling to finish, and because of my own mistakes, I didn't finish them well. And I'm going to show to you why, okay? Then in the class 2, the 3 pillars for faster and more efficient treatments. And in the third class, we'll go from the theory to execution. Meaning, I'm going to show to you how you can plan and how you can achieve better results and faster results in orthodontics. So this is going to be this way. In this event, in this class now, I will reveal how to cut treatment time in half and get 100% better results. Meaning, well, let me clarify to you. What I mean here is, I'm going to prove to you now, undoubtedly, that if you don't follow this path, you're going to be in the hands of the companies. Pay attention to that. You don't want that in your life. You don't want that in your career. If there is a faster way to treat orthodontics, not about device. It's not about device. It's about increasing the way you do orthodontics, but in your mind. I'm going to show to you this during this 3-day class. At the end of this 3-day class of classes, you will know how to make accurate diagnosis, how to develop an effective treatment plan, pay attention to that, how to reduce the likelihood of errors during the treatment, how to achieve above average results in significantly less time. Yes, I'm not telling you that's possible. I'm sure this is possible, and I'm going to prove that, okay? And how to become a professional, valued and recognized for your work. A long time ago, I was thinking about quitting, quitting teaching orthodontics. Why? Because I was unsatisfied with what I was seeing in my classes, what I was seeing in my life. I would say my life. Why is that? Because I really believe that we can change as professionals, as professors. We can change people's life, people's career. And I was not being able to do that at that time. Why was that? Because I was not being able at that time to recognize the problems and to teach those solutions to my students. Because I didn't know that. Myself, I was doing the same thing that I was taught. Doing the same thing that I was since the day one in my practice was doing. And I was not being able to change that. And with time, because of my own mistakes, because I need to be very precise about it, my own mistakes, I just changed everything because of that, knowing what was happening. I was taking photographs of every case, studying and seeing what the problem, where were the problems located, recognizing the problems, and then drawing the right solution for them. That was the time when everything changed in my mind, and changed the way I was teaching orthodontics. And you see my cases, and you see the way I do that with my videos, just for my patients, just for my students. I don't want to teach orthodontics on Instagram. Instagram is not for that. I don't want to teach people how to do orthodontics just based on one video or several videos, whatever. I want to show to you that there is a right way to do that. So for profiting from this knowledge, for understanding what I'm saying in Instagram, I'm showing in Instagram, you must be an orthodontist. And from that point on, you're going to see that there is a right way to do things. And there is a wrong way also. So let's go on. Let's move on. You are going to understand the way to do orthodontics based on the diagnosis, treatment planning, and the biomechanics. How to link this tripod in a very precise way. And you're going to have results like that. Understanding the problem, drawing the right solution for the problem, projecting what's going to happen in the future, anticipating the problems because of the diagnosis and treatment planning will give you this path, and will allow you to go out of the problems, anticipating the problems, okay? That's it. Those cases are being treated this way, and the diagnosis and treatment planning will allow you to give this outcome to your patient. And fast, how fast? Much, much faster than what we've been doing. Not because of magic, not because I know much more than you, not because of that, but because I understood the way to do this and to show to my students how to do that. Okay? There are several ways, actually, to teach you how to do better treatments in your offices, how to achieve better results. And then we go on with the results, things like this. Faster treatment time. Why? Because you are not going to follow the wrong path. Meaning, you're not going to do something based on, I want to do that, I just want to try this way. No, you're not going to do this because you understand the way, the method. You understand the protocol. And if you anticipate the problems, you go directly to solve the problems in the origin. And you treat patients like this. You treat patients faster, like this case, for example, that was being treated for 5 years. And then she came to me in 10 months. We managed to give her this type of occlusion. So nothing here is magic. Everything is based on what is solid knowledge that our predecessor gave us. This is what it's about. Let me show to you more. And cases like this also that we can treat in less than 1 year, in this case 10 months, skeletal open bite treated with TEDs and based on the diagnosis. But don't just believe what I'm saying, just look at that. Look at this people that came to me to understand orthodontics. What are they saying? Is it rolling?
The protocol used by Professor Meireles is amazing.
Honestly, I think that from tomorrow everything will change, because when you see such good protocols and such good presentation, diagnostics, then you feel like you want to change everything in your own practice, no? And this is what I'm going to do by this experience since the very first day tomorrow.
It really goes through every step of the facial analysis and intraoral analysis, and it really gives you a clear and complex perspective of the treatment, and a complex treatment seems much more easy, clear, and well established.
So I can't wait to go back home and start this new way, a better way of treating patients.
The treatment time that we see here, it's amazing, short. We are amazed by the protocols that Prof uses and the way he levels the SPI, he distalizes, he corrects the asymmetries, how he deals with the vertical dimension, and all of these, they came from the diagnostic. And the diagnostic protocol, it is amazing, efficient. So I really appreciate everything I see here. It changes my way of seeing the cases, and for sure it's going to change my protocol of diagnostic and treatment.
Okay, so you can see that this is something that you can apply, not just me. If you understand the process, and not just me, I didn't invent nothing here. I'm based on what our predecessor said. I'm based on people smarter than us that told us in the past that this can be done this way. Don't do the wrong way. And I'm going to show you how to understand that better. Let's move on. What happened in my own life so I could change the way I'm doing orthodontics? Let me tell you some sad stories about myself. 25 years ago, I was coming from São Paulo to my hometown here in Salvador, and I started doing orthodontics. I was very excited about that at that time. You need to understand that, because I must show to you that you can do the same way I'm doing today. You can do a better orthodontics if you understand that what we are doing now, you are doing now, can be changed. Your way of seeing orthodontics sometimes with sadness because you're not completely satisfied with your results, with your treatment time, you can do differently. In orthodontics, if you understand this process that I'm going to teach you, you can see that all cases that come to you, they are solved. They can be solved in less than 1 year. Almost all cases in less than 1 year. And it's not about the device. It's never about the device. Put that in your head. From now on, you are not going to focus on the device. You're going to focus on the process that I'm going to teach you how to do that. Okay? So at that time, I had lots and lots of cases that simply stuck. They were like what I was seeing in my cases, and that made me very sad, was something that I was not prepared to see. Cases simply taking longer than necessary. Some cases I need to stop and go back. Some cases I was seeing the patient's profile before and after. I was not satisfied with that, because I was not paying enough attention to the problems. I was not even being able to identify the problems. So at that time, I started seeing many orthodontists from my country, from my own town, and I was talking with them. What are going on in your offices? When it happens this way, we had groups for discussing that, and the same problem. They had the same problem that I had. So I started thinking differently. Maybe there is something missing in my own formation. Maybe there's something missing, although I had a very good course, perfect course, meaning this University of São Paulo is a very good, well-known university in the whole world. Actually, for 2 years in a row, it's been rated as the most prestigious university in the world. But it's not that. It's not that. The problem was the knowledge that I needed was not just there. I needed something else. So I started studying diagnosis, biomechanics. I was trying to give this link, right link between these two points, two dots. I was here, good, and I was here, was good. But there was no linking between both. And I established those links just based on one thing, just based on solid knowledge in previous knowledge that orthodontics have for a long time, And that's why I started doing things differently in my office. Before we get into the content of the class, we will recommend you to watch on desktop for best experience. Write down your questions, yes, because you have questions, you probably have questions at the end of the class, and I will answer those questions. I will try to answer those questions based on what I know at the end of the section and help this teacher to get this knowledge to the whole world by taking photos and posting in your social media and tagging me there. Please do that because I want to know if you are satisfied with that and if you are with me, wherever you are. So thanks for being with me, and now I need to start with this. The future of orthodontics lies on the past. The future of orthodontics lies on knowledge. Knowledge. Between those two pictures that you see here, those two men here, with one with one very old computer, very old way of manipulating that knowledge, and then in the other side you see a very, let's say, I try to do that, this is from Midjourney, very technological gadget. Between those two men, there is a whole world in the middle. There is a whole world of knowledge that can't be disregarded. Can't be. We can't go from this point to this point without the middle of the process, understanding the process. If I give to you now a very beautiful gadget, a specific gadget with the most modern technology in the world, you're not going to be able if you don't understand what is there for you. So you need to understand that. That's why I tell you that for being here, you must understand the whole process. I'm sorry for doing that. I'm sorry for telling you that. There's no magic. There's no magic in orthodontics. There's just solid knowledge. And that's what I'm going to try to show to you now. Look, one of the things that you must consider in your life is this. What do you want for your patients? What is success from the perspective of orthodontics like me and you? Well, most of all of our pairs will say that this is what we need, our patients' satisfaction. And I completely agree with that. And what if I say that from the perspective of our colleagues, what makes us excellent orthodontists is this, excellence itself. Meaning I must deliver the best treatment that I can in faster time with less biological prices to pay, biological cost, and with a better refinement. Those people that are looking to you, those people that are seeing your cases, they are going to look at that. Well, good case, okay, how long did it take? 5 years. Well, 5 years is not a good time for treating a patient. Let's see the x-rays. Well, too much root resorption. There's something wrong here. Well, I don't like to match the finishing status of your cases. So this is bad for us. With our patients, by our own view, We must be recognized as good orthodontists if we do good things to our patient. So to have this type of recognition, you must focus on excellence in your work. Always excellence in your work. And that's what I'm trying to tell you now. How to bring greater efficiency to orthodontic treatments. Not difficult, not difficult. We must avoid some mistakes. Avoid the mistakes, these mistakes here that I'm going to show to you, and deliver orthodontic treatments more efficiently, safely, and with superior results. It is completely possible, guys. It is completely possible. It's doable. I've been seeing that for a long time now. I told you. I was there. So I struggled to get out of that place to be in a better place. And now I can sleep well, thinking that my treatments, of course we have bad cases. All of us. All of us. But nowadays, I see that I can deliver to my patients the best treatment that I can do based on science, based on protocols, and based on knowledge. I'm going to show to you how, during these 3 days, again, remember, for being, for having the best experience in these 3-day classes, you must watch the 3 classes in the sequence, okay? This is the first class. So we are going to focus on some mistakes that are very common in our practice so we can avoid them. Let's see, the main mistakes are just based on this. If we don't focus on the diagnosis and planning and then execution, I need to tell you, it's not going to be right. It's not going to work. I promise you. But the other side of the coin is, I promise you that if you pay attention and if you study this that I'm going to teach you now, and if you go through this path, I'm pretty sure, completely sure, that it can change your career. That it can change and will change your life, the way you do orthodontics. You know, guys, I'm very enthusiastic about this because, well, from 20 years, more than 20 years now, 25 years, being here, practicing orthodontics, teaching orthodontics, what I see is this. I'm happier now because I can do better treatments. And I'm enthusiastic about that. You know, today I have a good practice in my own town. I have good students. I have this face-to-face classes. And this is enough for me. Why I'm here with you? Because I've been receiving lots and lots of questions every day. And I see people from all over the world, from Europe, from Africa, from Asia. I was now in those three continents, giving face-to-face classes. But I can't reach everyone. And people ask me, Prof, look at this case. Do you think that I'm doing the right thing here? And sometimes I'm very shy of telling them this. You are missing the main thing here. You are missing this point. You are not understanding the problem. How can you treat someone without understanding the problem? You can have the best device that your money can buy. But if you don't understand the problem and deliver sometimes very simple solutions, you're going to have very bad trouble, very, very bad problems. That's what I'm trying to tell you now. And let's go from this, the diagnosis, to the right process of treating our patients. I like this. I like this. Make sure that they're seeing. I can see how you're seeing now. Look at this forest. Let me just put the sound, a loud sound. Eles podem ver? Okay. Scary sound. What is this? What does it mean? You try to think about you in the border of a forest, like this. And you need to go from this point to the other side of the forest. But you don't know the path. You don't know the way. And if you know the way, if you have a map in your hands to know the way, how to go from that point to the end of the forest, to the other part of the forest, you're going to be safer. And this is the treatment planning. And the treatment planning is based on the diagnosis. So for going through the forest safely, bota mais baixo? Okay. Let me do good. So from going to this point to the other side safely with a map, you're going to be like more confident. But wait, what if you have something to face during the journey, like the dangers during the journey? What do you need? You need tools for that. What are the tools? The tools are the biomechanics that you're going to teach you throughout the process. Biomechanics will rule the way that you go from this point to the other side. And if you master the tripod, you're going to be a better orthodontist. For sure, okay? First of all, for this class, I picked 3 points. And I'm gonna teach you now, I'm gonna show to you now how these 3 points will help you. And if you don't have complete knowledge of the 3 points and master those 3 points, you may have a very bad time. First of all, I picked this one. Are you able to identify the problems adequately? Let's focus on this. This is the first point that I'm going to show to you. Are you able to identify the problems adequately? And I'm going to tell you something. Based on my own experience, you are not. You are not. Now, you are in that point that you are struggling to understand that. I know that. Why? Because I've been there. I was in the same place. I've been there. And I was just using my tools that I had at the time, like the cephalometric X-ray, the panoramic X-ray, CBCT when necessary. I had the casts, I had the photographs, I had the diagnosis, like my own interview with my patients. But I was not being able to give this link. I was completely lost at that time. Let me show to you. The first thing that I'm going to show to you now is this photograph here. You know, this case was treated, I treated this patient 26 years ago. I know you may look at me, it's not possible because you're too young. Yes, I'm young, but not that young, unfortunately. But time comes for everyone. Let's see. What I see here is this patient at this point. She came to me when she was 13 years old. 13 years old with this face. And she was under treatment. She was being treated. But there was a problem that I was not seeing here. This is the problem that I was not seeing here. What is going to happen to her face during growth? And pay attention to that. Is it possible to treat this patient at this time with a compensatory treatment? This is the question that I pose here for you. Is it possible to treat Ana Paula, 13 years old, with orthodontic treatment without surgery? What do you think about it? It depends on the location of the problem. It depends on patient shift compliant. It depends on the magnitude of the problem and the pre-existing compensatory position of upper and lower incisors. So pay attention to that. I can't say if it is possible or not to treat her now unless I can identify the problem. So Ana Paula came to me like this, 13 years old, and I ran my sequence. Not at that time. That time I was just thinking about the problem, and I just figured that problem would be located in mandibular growth. And if it was mandibular growth, the endochondral growth may be difficult to manage. How come? Endochondral growth is in the apex and the symphysis of our long bones. We grow despite of the impact that you give to that part of our bodies. Endochondral growth is an adaptation to provide growth in this type of area of very big strain, big force, big impact. So if I'm dealing with a prognatic patient, a real prognatic patient, I mean, this is not maxilla, this is not maxillary deficiency. The problem here is the mandibular growth. Being mandibular growth, well, I don't know how is it going to end. So let's move on. I go do the diagnosis. Of course, nowadays I can do that, but I'm going to show to you what I should have done at that time. By luck, I did the right thing, and I'm going to show to you what I did. So I have, in this case, in her case, let me show to you here, I have the lower anterior third of the face increased, and I have a bad relationship between the upper and lower lip, and this is something that is very common in class 3 patients. So this is something that I can change depending on the origin of the problem and on the source of the problem, or I can't change. So it depends on what I'm doing, okay? In here, in her case, I had this prognatic profile, this increased volume of the lower third of her face, and when I see her profile here, look at that. I have a class 3, but I don't know where the problem is located. So I had a class 3 case here. In her case, what I see is almost straight profile, 107.8 degrees. And when I go on with my evaluation, look at that. Again, I didn't do that at that time. That was the problem. I was like lost, but I thought maybe this problem is located in the mandible, not maxilla. And luckily, I was right. So what I did, let's move on. So she had at the time a good maxillary sagittal positioning, and look at her going on with her profile. This is important here, the relationship between the total height from the nasion to the menton and the lower anterior face height. What do I have here? Increased lower anterior face height. Pay attention. Pay attention to this specific topic here. I'm coming back to this point later. So I have lower anterior face height increased, also increased. I have this bad relationship between the upper lip and the lower lip with a short upper lip, not because it is really short, but because of the mandible. We have actually a long lower lip, which is very common in prognatic profiles. Pay attention to that. Let's move on, and we have this condition. So what's going on now? I have a good vertical relationship, not that bad, and this is something that's not calling my attention now. But let's move to this point. Pay attention now. Don't sleep. Pay attention. Look, what I see here is the cephalometric X-ray. What I'm looking at here is the numbers. And during this class, I'm going to show you that there are some numbers that are very bad, won't help us. And there are other numbers that can help us. So let's move on to this point. Look at this. And look at this. 1997. This is when I when I saw Ana Paula the first time. And the numbers, let me show to you with more magnifying lenses here. We have a maxilla of 85 millimeters. Remember, I told you, her maxilla is not a problem. Maybe I have a little bit of maxillary sagittal deficiency, but it's not clear. Let's consider a good starting point. I will think as the maxilla as my good point to start with. And I have, in this case, if I'm going to make Meireles analysis, I have the relationship between maxilla and the mandible. For a maxilla of 85 millimeters, I will expect to have the triangle. I'm going back to the triangle. I've been teaching that for a long time now. Not me, because it's not mine, it's Meireles. But I've been focusing on that for a long time. If you're not with me so frequently, I'm going to show to you. Well, for this maxilla that I considered a good maxilla, I would expect 100 5 millimeters to 108. What is actual number here? She has maxilla from condyle to gnation of 130 millimeters. You see? Prognatic. And lower anterior face height. Expect for a good relationship, sagittal relationship, the triangle to be good, to be perfect. We would expect 60 to 62 millimeters. We are facing here 73 millimeters, more than 10 millimeters. And this patient came to me, although she was 13 years old, she was like this height, and she came to me not having had experienced yet the menarche. Can you understand that? Growth is there. Mandibular growth is there. How come you treat this patient without knowing where it's going to end? Don't do that. Don't go this way. It's wrong. So let's move on. And we have also the relationship between the maxilla and the mandible. Look at the width appraisal here. Minus 15 millimeters. And the lower incisor in relation to the mandibular plane. The IMPA, 65. Oh my gosh, now I know. IMPA, the best IMPA that there is 90. 87 to 90. It's wrong. It's wrong. I'm going to show to you why. But let's move on. So this is her when she came to me with this occlusion, class 3. You see she was under treatment, and I don't know what was the planning, but I see that our colleague here, he was losing the game. He was beaten in the field, of this game. Why? Because he didn't know what's going on. Not his fault. Not his fault. We are not taught how to deal with this type of treatment. And now I'm going to ask you something. Do you think that I, at this point, tried to go on with the compensatory treatment based on what we are seeing now? So let's just remove the brackets, bone again the brackets, and now I have a better device for that. No, I don't have a better device. I have the magic device. I have an aligner. Forget it. Forget it. There's no device to treat this because you're dealing with growth. You're dealing with something different. Nature. Mighty God. He made her this way. And she's still under growth. Uncontrolled growth. So let's move on. And now we can think, well, but I know that there are some people treating those patients using the chin cap. Chin cap is good. Chin cap is magic. Chin cap can control the mandibular growth. It can't. I've seen many articles, many people doing this for a long time now. Hideo Mitani is one great orthodontist that treated this way with good results, but with extremely compliant patient treated from 5 years old to the end of growth. The growth completely ceased. 21, 22 years old. I don't have this type of patient in my offices. I don't have here in Brazil. Maybe you have it, okay. But again, are we completely sure that this is from his article, completely sure that if we just release our patient is not compliant enough, what's going to happen? It will recover growth more than what was going until that point. It's written here, not me. Hideo Mitani, the guy that's really good at doing that with chin caps. But what chin caps really do, in most of the cases, it does this. Look at this. I will apply the force against the growth, but it will not, in most of the cases, in most of the articles that I know, I will not really seize the growth. I will redirect the growth. And redirecting the growth, increasing the lower anterior face height may be tragedy, may be very bad. You're just exchanging problems. You're having a class 3 prognatic and you're transforming those patients on a very, very high lower anterior face height patient. I don't know if you want to do that. If you want to do that, pay attention. Maybe your patient will not be satisfied with the outcome. Okay? So this is what's going to happen. Remember, her lower anterior face height, it was already increased. So pay attention to that. When you see cases like this, treated this way, you see, well, I want to treat this patient without surgery, but you are focusing on the occlusion. The occlusal view may be sometimes good. I'm going to show it to you tomorrow that sometimes are very bad. But okay, maybe you're treating the occlusion. But what's going to happen to a patient's face? Are you really following this on Instagram pages? When you see people using TADs for retracting lower anterior teeth to correct a class 3 in a hyperdivergent patient with nothing of bone, makes no sense. Complete lack of understanding the problem. You can't do that. Of course you can if you want, but it's not fair to your patient because you're going outside of the bone, outside of your boundaries. So take care. So I don't want to do that. I know that based on, again, McNamara triangle, I have ways of dealing with this type of malocclusion. I showed you before in other classes how to deal with the vertical anterior short faces. We can do that in good ways, and there is the right indication and the completely wrong indication for that. You can do that to fasten up your treatments, knowing that the vertical can help you. But the vertical can help you when there is a possibility of that happen. But sometimes the vertical, increasing the vertical, is poison. It's quite the opposite. You are ruining your patient's profile. So we need to understand all the problems, guys. We need to understand where the problem is located. Please, pay attention to that. Pay attention to that. I genuinely want to help you on that because I've seen many disasters coming from this point. The lack of understanding this, which is not something new, actually is very old. Moving on, I know that I have a triangle. Of course, you can use other types of ways of seeing, cephalometrically seeing your patient, but I like this because this is not an absolute measurement. This is a relative measurement. It will depend on the maxilla, on the mandible, and will depend on also on the lower anterior face height, which is something that, in this case, is not good for me. So I know that when I increase or decrease the lower anterior face height, even without changing the number of the maxilla and the mandible, I will change the sagittal relationship between maxilla and mandible. This is how we treat patients with maxillary mandibular excess, but lower anterior face height decreased. Not when I have already increased lower anterior face height. This is something that may be very bad for our patients, like Ana Paula's case. So what do you think about it? Let me ask you something. You already know that she has the lower anterior face height increased. She has a very strong mandible, so she's a prognatic. Also, we have other characteristics. The shape of the mandible shows us those characteristics. So I see that she is to be treated. And she came to me like, can I be treated without surgery? Because I went to several orthodontists and they gave me like this, this diagnosis and treatment planning. Is it possible? And I told her, no, I wouldn't do that without surgery. Why? She was 13 years old, undergrowth, before a menarche, and I had this stable here to guide me. This is something old also, okay? I use this table to understand if I can or cannot treat a patient in a compensatory way. First thing here, let's put just negative or positive in relation to these 4 points. I mean, the first important point, which is not here in the table, is patient's chief compliant. She came to me saying, I want to be treated, but I don't want to go to undergo surgery. Is that possible? So now I need to understand what I have here. Patient's age, it's extremely negative. Why? Because the problem is located in the mandible and she's still undergrowth. If it was just maxilla, it was another thing, but mandible. So I'm linking the patient's age with the patient's or the problem location. The location of the problem was mainly mandible. Mandible. Mandible, remember, what do we have in mandible? Endochondral growth. Is it possible to manage the endochondral growth? No, it is not. It is not. Or at least, if you believe that it is possible, at least it's not something that you can rely on. You can try. Of course you can try. If you believe that you can do that with chin cap, okay, you can do that, but it's not something that's predictable. So I put here in the negative side of the chart. The magnitude of the problem, very difficult because this patient had already pre-existing compensations. So I had many problems that showed me that for her case, the best thing to do was just wait. Just wait. And that was what I did. I waited. Waited for what? For growth to cease and to see how was the real problem. The magnitude of the real problem is now here, is now clear for me. So can you imagine treating that type of face with this outcome? Came to me in 1997, I told her, go home. I just referred her to a periodontologist so she can do the grafting in the lower incisor region with attached the gingiva, and that's it. And let's wait. And then when she came back to me 2 years after that, 1 year after menarche, I saw the case. And now I'm able to understand the problem. Can you understand that, guys? Please, think about you in the other side of the screen. Think about you, having a patient like Ana Paula, 13 years old, and you start treating her because you were unable to understand the location of the problem. And how can you do that? How can you do that? Simple and plain diagnosis. Simple and plain treatment planning based on the diagnosis. You could choose whatever device you wanted. In this case here, at this age, you would fail. A very bad fail. So don't do that. And then Ana Paula came to me. Look at this now. We have her in 2000, almost 3 years after the first consultation. And she came to me 16 years old. So 1 year after menarche, she had like a late menarche. And now I can see the case. Now I can see that for her, it's not possible to treat with compensatory measurements because now she feels that she's not beauty. Now she has another complaint. I hate my chin. I hate my strong chin. And this is very common in patients like that, to have this imbalance between upper and lower lip, showing this more brutal profile. They don't like it. They don't like it. It's not delicate. So she came now to me with another chief complaint. What if I treated her at that time? Fail, completely fail. Okay, so completely failure. So we have now this, and now we compare before and after, see that we really can't do anything for her. Look at these numbers here. Let me show to you the problem. The magnitude of the problem now is much, much greater. Now we have a maxilla, same size as before, but look at her mandible. Wow, so not possible. And here in her case, what I did, treated surgically because I wanted to change her profile. I wanted to change her occlusion by means of orthodontic preparation for orthognathic surgery. There's no other options. No other options. Some people look at these cases here. I say in a good way, look at this. I'm not criticizing anyone. I know that we have some problems when we do this type of treatment planning. And at some countries, we have some patients that they won't go surgical. But look at this. Treating a patient like this without surgery means that you must go distal with mandibular incisors. What is the size of her mandible? She's hyperdivergent with a very narrow symphysis, nothing of bone. I'm going to show to you distal to these roots here. You may want that to happen. You may want to treat this patient because she doesn't want surgery, she doesn't have the money. I don't know, many other options, but you can't do that because you are compromising your own treatments, your own future as orthodontist. So let's go on. We have here before and after. Look at this problem. So the problem went on and on and on. Not possible to treat this patient without surgery. So if we compare the numbers and between those two phases, two specific points, 97 and 2000, what we see here, we see that her mandible during this growth period grew 15 millimeters. Her maxilla, same size. Problem was located in mandible. So nowadays, it's completely clear for me. It's completely clear for me because now I use 100% of my cases the same protocol. Meaning, I will run the sequence of diagnosis, I will go to the origin of the problem, understanding everything based on the problem, and then I will establish the best treatment planning. I would never treat a patient, a growing patient with a severe mandibular protrusion and hyperdivergent patient. I would never treat this patient prematurely. I would advise you to do the same. Wait and see. Wait and see. It's better for you. So this is the first problem that I want to show to you. Here is Ana Paula before and after surgery, and here we have her occlusion. Take a look at this occlusion. I'm sure that I know what you're thinking now. Take a look at this occlusion and tell me what you're seeing here. I'm sure that you're now criticizing me and saying, oh, Prof, those incisors, The incisors are not 90 degrees in relation to incisor-mandibular plane angle, and they are not, and they can't be. I'm going to show to you why. So this is what I have. You see a grafting, gingival grafting here, and we have here 5 years after surgery, still stable. So everything is all right, okay? First case. And let me show to you another case that I want to prove to you now that it's not based on just on the magnitude of the problem. This is another case treated a long time ago with 18 years follow-up. I'm sorry for the Portuguese here, I forgot to translate it. I have here the situation. Patient lost anterior upper and posterior upper teeth, and we have a class 3. We have a class 3 with this cross bite, anterior cross bite. And the problem now is, can I treat this case without surgery or with surgery? Try to figure out now what you could do in this type of patient, with or without surgery. Look at me. I'm looking at you now, and I want to hear from you, with surgery or without surgery. You don't have enough information to see if the case is surgical or not. Remember, it's not about occlusion. It's never about occlusion. We will deny that. Do that with me. Stick with me with this. Deny that. Don't accept this. When people tell you Invisalign is the best appliance, self-ligating is the best appliance, conventional is the best, there is no best appliance. There is a better orthodontist, and this is what we are going to see now. You are going to be a better orthodontist if you don't believe in those lies. It's not about the appliance. I've seen people saying that, well, in the past I would treat those cases I saw a case yesterday, one orthodontist say, in the past I used to extract premolars for treating biprotrusive profile. And nowadays I don't need it anymore because I use Invisalign. And with Invisalign I can do distalization of both arches at the same time, and then I will do the IPR. My gosh, it's complete nonsense in my mind. Why avoiding doing the extraction of premolars and doing IPR? Do you know that if you shorten the distance less than 1.5 millimeter between roots, and you do that a lot when you do the IPRs, you are really decreasing the height of the crest, the bone crest, because it needs at least 1.5 millimeters. And you are decreasing that number. And then you're doing a treatment that will take longer, and with the need of doing with TEDs, because you're not doing the distalization and of upper and lower at this, both upper and lower at the same time, without anchorage, because after distalizing, opening space, and people just show the space being open, it means nothing to me. You need to understand what's going on in the occlusion, in the face, and then they will go retract. How come not losing anchorage again? Teeth, they don't know what appliance is being used. They know what you, as an orthodontist, are doing. Let's go on. So I have this patient here, 2001, and he came to me like this. So I ran the sequence of, at that time again, I was not doing that this way. I was trying to figure out the problems. I was trying based on several articles, and there's something that I was not taught in my post-graduation program to do this way, so I would just try to do the right way. I was trying to do that. And we have here this is Jose Carlos, a very good guy, and he came to me like this. Look at that. Although he has the class 3 occlusion, he has a class 2 profile. Huh? Almost class 2 profile. We have now this condition. So when I go to the diagnosis based on the facial analysis, based on his profile, what I'm seeing here is there's no problem in his face, not surgical. Although we have the magnitude of the problem seems to be very large, but the face is protecting him. Huh? And we go on. Everything in the face shows me that I can treat, distalizing lower and going in the upper. I can keep that position. So for that, I will also run the sequence of evaluation of the cephalometric measures. And we have a good inclination of incisors. Everything was good, guys. So what can I do here? Well, what I see here is everything is perfect. His face is okay. A little bit of lower anterior face height increased, which helped him to camouflage, to do the camouflage of the malocclusion in his face. So this is what's going on now. And knowing that the problem was not located in his face, I can treat him just using dental treatment, just moving teeth. Okay, again, I went to the cephalometrics, to facial analysis, smile analysis to understand the problem. And now, is it possible to perform a compensatory orthodontic treatment? Because he came to me saying the same thing. I will not do surgery. I don't want to. If you are saying surgery, I will run out just now. And I told him, it's completely possible to treat you without surgery, because I know that although I don't have the opportunity to stimulate mandibular maxillary growth and maxillary anterior displacement, which was a good thing to do in his case, I had the other location of the problem, just teeth. Magnitude of the problem, not that much. Pre-existing compensations. You saw the inclination of the incisors. Good. No compensatory, no natural compensations. No natural camouflage. So I had everything in my hands. So I treated him this way, with extraction of lower premolars. Don't tell me that extraction are not used anymore. Don't tell me that. I'm not going this way. This is science. I'm not going to magic and stuff like that. Yes, we do extractions. a lot, because we don't know how to grow bone. We don't know how to treat those patients growing bone when we do this type of movement. Not proven. That's it. And here we have it. So we have after treatment, and here the compensatory treatment finished, and we did the retainer 4x4. It's kept for 10 years, and then we remove it, and here we have the prosthesis in position, and everything is right. So everything is right and very fast because of the diagnosis. Before and after, comparing the inclination of incisor, what changed? Just occlusion. Just occlusion. And that's what I wanted to do. And here we have, after some time, 9 years after finishing the treatment, when we removed, actually, the retainer fell off, so he didn't come back until he saw that happening. Look at this, guys. The occlusion is growing older, it's aging. Look what we have here, more recession, and it's proven that with time it's going to happen. And now we have 2020, and he came back to me, and now I told him, let's close those gaps. Now I can use aligners. I can use whatever I want. I can use his finger to do that, if he sticks enough for doing the movement. So aligners did that, just 3 aligners, and then we close the space. That's it, and now we have before and after, 18 years. We grow older, you see the volume of the lips are changing, we have less volume of his lips, we have this, this is before, look at the exposure of upper incisors, everything we know, everything that we know. I love these cases, when you see cases like that, and we compare for a long time, we see before and after what's going on, growth takes, aging takes place, and that's it, okay? Here's going, look at his profile, completely kept, nothing changed unless, out of this volume of his lips, which is expected also. Nothing related to the treatment and with our options, just what's going on with time. Let's move on now to the second. Let's see how it goes here, because I need to control the timing here. Yes. The second problem here, the second topic here that I'm going to address now is, are you using the most appropriate cephalometric measures for the case that you are treating? So what are we doing? Is it really necessary to use the cephalometric measures that we are taught to use? Are those measures good or bad for this patient? I'm going to show to you that some cephalometric measures are not good. The first one I told you before is the incisor-mandibular plane angle. Not a bad cephalometric measure, not at all. Of course not. Who am I to speak bad things about Tweed? He did that in the 30s of the last century. Genius of the specialty, genius. But the problem is that at that time, what he wanted to do is just to do compensatory treatments. So if you use that for average, it's good. But if you use that for extreme treatments, it's bad. And let me show it to you. So we have here this, for class 1, horizontal pattern, horizontal patient. Okay, we can understand the IMPA. IMPA is a good measure. But what if we have a different profile? And now we're dealing with vertical profiles. Now we are dealing with hyperdivergent patients. Those hyperdivergent patients, they are not average at all. They have nothing of synthesis. Believe me, when you see people doing that, putting TEDs for distalizing lower anterior teeth, 5 millimeters, 8 millimeters, ask them, where's the bone? Where's the bone? No answer. No bone there, okay? So why is that? And why can't we trust completely in this? Because the mandibular shape is different. The mandibular shape in those patients, they have this, usually they have this retropositioning of the symphysis itself. So the symphysis now is crooked, is different from a class 1. And what can we do now? We must accept, because we want, at the end of the day, you want to position the teeth inside the bone, not outside of the bone. So this is knowledge. Solid. We can't fight that. We can't. And here we have, so in this case, the number that we have is not anymore 87. And it can't be 90 or 87. Why is that? Because the relationship between the basic, the mandibular plane, and the symphysis, the angulation, the retro inclination of the symphysis now must be obeyed, must be kept. We can't change that. So we have here a different number. And this number is his number. Look at that, guys. I could put here like hundreds and hundreds of articles showing the same thing. Look at that. This is 1996. The anterior alveolus, its importance in limiting. Well, it seems I didn't even need to tell you that, because it's there for a long time. But people are fighting against that. Still today, nowadays, 2023, we are fighting this evidence. Look at that. It's not possible. So we have boundaries. We must respect boundaries. Otherwise, we will have iatrogenic sequelae that is going to be on you if you don't respect that. On you, orthodontist. Okay? So respect that. Please. Please. And so we must understand that this is not a number. This is the anatomy of this hair, the shape of the symphysis, and the relationship between the incisor and its shape. The shape of the symphysis must be preserved. Not the number. Not the number. So we have here the position of the incisor is good, but what is the number here? 70 something, 76, something like that. So if you go to discuss with your surgeon, or she or he may tell you, I want 90 degrees. How come? Tell me. How can you do that? Don't think about orthodontics as something that is inside a bubble. It is not. We must remove that patient from the bubble, study that patient, and see what are the problems of that patient. That one. Jose, Antonio, John, Michael, Helen, they have names and surnames. They're not average. Believe me, if you do this, yes, in the beginning it may be harder, but changing is not easy, never easy. But when you go to this, from this here, average, to this sophistication in your diagnosis and treatment planning and biomechanics, you see that everything is going to be faster. Everything that you're going to do will satisfy you and will put you out of that mass of people that don't want to think. Okay? IMPA is that. So we must respect this. Don't go to the number. Go to the shape of the symphysis. Understand it. Understand that vertical patients, they are very difficult to treat. So if we have this, the inclination of upper and lower incisors, they must be, we can't take into consideration other points not out of the shape of the area. Look at this other example for you. If I'm applying the 1 point NA for the inclination of upper, what's going to happen when I change something here, out of here? Even not changing anything, I will change the number. Why? Because that point is going to affect the measurement here. So everything must be considered based on the individualization. Pure and simple like that. Pure and simple like that. Your patient, his name or her name is not average. They have names. Okay? So we are going to respect that. Well, every measurement that you use that take into consideration other points other than the area that you're treating will be affected by the position of that area. So many measurements that we use, many measurements that you are going to use in your practice, they may be different from what you're seeing in your patient. That's the point. What I mean is, cephalometrics is good, very good. I use cephalometrics a lot. I have a quote now to tell you. My mentor, Leopoldino Capellosa, good, one of the best orthodontists that I know, he used to say this: you must understand everything of cephalometrics to understand that you don't need cephalometrics in numbers. This is genius. Genius. What he's telling? He's telling us that when we do that, cephalometrics as numbers, number-driven, let's say, we are putting our patient in average, and we are not really giving a good treatment for those patients. So if we do understand the measurements, and if we understand that there are variables that we can control, and they are unique, we are not using the measurements, but we understand the cephalometrics. Pure and simple, okay? That's what I'm telling you now. This is what I teach in my courses. In the course that I give, diagnosis and treatment planning, I focus on that. I focus on this type of thing, okay? So we have here another measurement, which is the number one, the incisor in relation to the palatal plane. It's a good measurement because it's not considering a point far from the problem, but also something that we must consider with some reservations, okay? Look at these numbers now. Focus on the numbers now. I want you to see this patient and look at this number. The incisor mandibular plane angle of this patient is 84 degrees. 84 degrees. And if you want to treat this patient surgically, you must think about, I must go to 90 degrees. 84 degrees in this patient is already bad for him. It's already outside of the bone. Look at the symphysis of this patient here. The symphysis is nothing. It's narrow as nothing. It's a needle. And the incisors, they are outside of this needle. And the number is 85. So we have a problem now. If you just believe on numbers and you are number driven in orthodontics, you are going to give 90 degrees, 87 degrees. In a case like that, it's completely impossible. So what I'm trying to tell you now is, if you stick with the individualization in place of the numbers, the average numbers, you're going to put yourself in a safer position. So the problem is not the number, is the position of the incisor in relation to the bone width, to the bone here. So sometimes we see a number like that, and we think about the average, and thinking about the average and looking at the shape of the mandibular symphysis, we think, wow, actually, I need to decrease that and to put that number out of the average, more out of the average that it is already. So 85 is too much for him, maybe 70. But in his case, it's good for putting his incisor inside the symphysis. If you look at the center of the symphysis here, it's, let me see the measurement here. If we look at the center of the symphysis, in this case here, what we have is completely different from 90 degrees. You see, a retroinclination of the symphysis. And let me put the center of it, look at that. It's 73 degrees. Maybe 73 degrees is good for this patient. Okay, so guys, this is individualization. Remember, hyperdivergent patients, they don't allow us to do much movement. But if we have horizontal patterns, this is hyperdivergent, horizontal patterns are completely different from this. This is vertical. Vertical, nothing of symphysis. Respect not the number, but the shape. But if you have patients like this, well, class 2, div 2, patients like this, You can do whatever you want. No, I'm not serious. You can do more. Let's say more, but not wherever you want. But look at the symphysis here. 100 degrees, 110 degrees. Good for her, not bad. So respect the individualization. That's the point that I'm focusing here now. This is centered. This is also centered, but with more room to do the inclination, to work the inclination. Here is the center, so we have more possibility. We have nothing of possibility of inclination here. So respect the individualization. This is the most important thing regarding cephalometrics. And when we do that, we stick in our boundaries. Like that. Still in our boundaries, because we have room to do that. So this is not about the numbers, guys. Never is about the numbers. Numbers are references, but individualization is the name of the game, always. Okay? Well, let me just grab a cup of water here, because as you see, and I'm very enthusiastic, I speak loud. I'm sorry for that. I'm Brazilian. Okay, and now we have the last part of this class today, which is, are you really employing the most suitable biomechanical strategies for the case you're treating? Well, sometimes we have cases like this, and we think about, let me just go on, I don't want to call your attention on the article, but on this case here, look at that. People come to you very frequently nowadays asking for aligners. This is probably in your clinic. I don't know if in your country like this, but here in Brazil is the most common thing. I want aligners. I want to be treated, and they don't say align. They say Invisalign. Good device. But, well, is it really something that's going to help our patient? When you see cases like this, what's going to happen? This is diagnosis. What's going to happen now? Without my mechanics to derotate this canine. So if I go with the Invisalign or whatever aligner I use, I need to open the space. First of all, I have 7.5 millimeters of width of the canine, and when I measure the distance between these 2 points, in which the canine must stick inside, to go inside, what I have is just 4 millimeters. So I'm short in 3.5 millimeters here. What can I do? And in addition to that, I will need to rotate this canine approximately, let's see how it goes, approximately 66 degrees. This is mathematical. Yes, kind of. Why? Because I need to rotate. And I know how it is now and how it needs to be. So 66 degrees. What's going to happen when I stick like 2 degrees, if I'm optimistic enough, and I say 2 degrees per aligner. 2 degrees per aligner, and each week this patient's going to change the aligners. Is it possible? No, it is not. But let's say it is. It is not, but let's say it is. So if I just go with this math here, I will need 33 aligners for that. So this patient came to me and I told her, why not use fixed appliance just for rotating this tooth? And after that, I can use aligners. And I promise you, you will not be with braces for more than 3 months, for maximum, okay? She told me, do you promise that? Completely. Trust on me. So why not doing this, guys? Because this is completely different. I can do that very fast using the right device for that. When I see people saying that I just use aligners, or I never use aligners, or I just use conventional brackets, or I just use self-ligating brackets, I don't believe your patients, they are aware of that you are using just one tool for treating all. Is that tool really suitable for all treatments? Of course it is not. Of course it is not. Sometimes you need to use aligners. Sometimes you need to use devices like MARP. Sometimes you need to use I love self-ligating brackets, but I use from knowing the problems that they have, their Achilles heels, I know that they have. So I will provide for the patient the best treatment that I can, giving to them the best option that I can. In this case, the treatment with aligners wouldn't be a good treatment because of the canine, which is very difficult to rotate. And I provide for her this treatment with clear braces, sapphire braces, and bends and loops. And that's what I could do in just 3 months, to rotate this tooth, to align those teeth using flexibility of the appliance and the flexibility of the loop. So this is something that I could do for her very fast, and when we reached 3 months, I told her, now we can go with aligners. And she told me, no, I don't want. Let's finish it. And 2 more months, we finished the treatment, just rotating that tooth. That's what I want to tell you. You must choose the best device, the best strategy, the best biomechanics for each case, for each patient. And it's not about what you want to use. It's you, your preference. You are not, it's not fair with your patient. That's what I want to tell you. So this is what I did for this case. Look at this. The aligners just in the upper arch, and in the lower arch we used the strategy of fixed appliance, doing that in just 5 months at all. Entire treatment, 5 months. Another alert for you is this. Another thing that sometimes we don't pay enough attention. Diagnosis. We need to understand what we are doing when we do some types of treatment. For example, this. What if I do the extraction of the lower premolar without extraction of upper? Guys, this is something that is going to happen. In most of the cases that you're treating, if you just do the extraction in the lower and you don't have the lower third molar, the upper second molar is going to be hanging, and eventually when you remove the appliance, you're going to have this outcome. Why is that? Because you are shortening the mass in the lower arch. When we have this in no contact with upper, I'm going to show you tomorrow that this is possible to do. It is possible depending on some things. If you do this way, you are going to have this outcome. This is from an article showing the strategy of just extracting lower force without extracting upper. Very good treatment, but you see the second molar where it is. It's now erupting. It's now extruding without contact of the antagonic tooth. So this is another thing based on diagnosis that we must consider. I've seen cases like that in which patients sued the orthodontist because of this type of mistake. So don't do this type of mistake. Tomorrow, I'm going to show to you ways to do that without going through this path, okay? Biomechanics, diagnosis, and doing that the right way. What I'm doing here, last case. Are you still awake? Last case. And this is going to show to you how I had my own mistakes in orthodontics. This case, patient came to me long time ago, and she wanted to be treated without surgery because she visited other orthodontists before, and she told me, I don't want to undergo surgery. At that time, 2001, 2002, around that period, here in Brazil, we had that trend. Everything was about mini screws. So first thing that we would tell our patients, well, I don't know what I'm going to do with you, but mini screws for sure. For sure. Mini screws for everything. So in her case, I based my treatment on her occlusion, and I just disregarded her face. And let me show to you where it ended up. Look at that. So I wanted to close the bite. anterior open bite, and for closing the bite, my strategy was a little bit of extrusion of anterior because she had that inverse smile, and a little bit of intrusion of posterior and extrusion of anterior. But intruding posterior, it comes with a cost. It comes with a very high cost sometimes. What was the cost here? Let me show to you. I'm doing that in a hyperdivergent patient with this huge mandible, and when I do that, I will rotate her mandible with the fulcrum here. What's going to happen? Now I'm doing quite the opposite of the things that I've been teaching to you. I'm going against the correction of the occlusion because of my lack of understanding of the problem. So you see, I told you, I've been in the same position. When I use just the occlusion as my way of treating patients, disregarding the whole picture, I would end up like this. And that was bad. Look at that. So I had the intrusion. What's going to happen to her mandible? Mandibular counterclockwise rotation. Mandibular counterclockwise rotation, increasing the problem, the occlusal problem. Because the class 3 now is increased because of my bad biomechanics, my bad choice for the case. Look at that. So I'm doing that this way. When I did class 3, I did I positioned the mini implants plus the transpalatal bar away from the palate approximately 4 millimeters, and now I'm intruding posterior to close the bite by means of intruding posterior and extruding anterior. Look what's going on. Look at that. What's going on here? I'm really increasing the problem because of the rotation of the mandible. Now she's more class 3. And now I need to go against the class 3 using elastics and elastics and elastics. And because of that, my treatment took much, much longer than necessary. Because I didn't understand the problem, and I chose the bad solution for the problem, and not understanding what was going on, I was increasing the problem, the occlusal problem. So it's not possible. The main thing about this case is it's not possible to do this without a cost. It's not possible to treat patients in the best way you can without considering the whole picture, not just the occlusion. This is about diagnosis. And we go on, you see, now after intrusion, we have the transpalatal bar 1.2 millimeters away from the palate, and we see that I'm finishing. I'm struggling to finish it, distalizing more the lower, using a class 3 elastics as anchorage, and now I ended up with more inclination of upper anterior because of the rotation of the mandible and because I increased the class 3. What happened here? Bad judgment based on just focusing on the occlusal diagnosis. Not a bad treatment in the end, but I should have done better than that, much better than that. This is a surgical case. I would never treat this case again without surgery. Again, it's not about the device. It's not about what you're doing. This is 15 years after that, she came back to me. She's after the treatment, good social smile. Of course, this is her social smile. And when we compare before and after, of course, she's satisfied. She came back to me several times because she was satisfied. I was not, because I knew that I could do better than this. This is 15 years after that photograph, so keeping a little bit of relapse, but not that much. But what we can see here is that because of the outer rotation of the mandible, I did a bad positioning of her mandible because of that. So, bad strategy based on bad diagnosis, okay? And finishing now. When you go to the internet, when you see this, okay, you see the internet is a lawless land. No law in internet. You see cases treated this way, you see just the occlusion, you don't see the whole picture, and you just say, wow, magic. I clap hands because I see before and after, but I don't see the way. I don't see the middle of the process. It's not fair with our patients. If we just show before and after without the middle of the process, you're not learning anything. And that's what you see. It's not about the internet. It's not about Instagram. Actually, I love Instagram. I'm there every time. I'm there when I can because I want to show the way I do things. Of course I do. Of course, I like to do that. I like to discuss cases in Instagram, but I'm not there to teach anyone. It's not about teaching. You're not going to learn orthodontics in my Instagram or any Instagram that I know. It's not possible. The Instagram is for those people that already knows orthodontics, okay? They know orthodontics and they want to improve or to know new strategies, to see things differently, just that. Just that, okay? And for sharing information, for advertising and other things. You are in Instagram not to learn orthodontics. Pay attention to that. And always ask about what's going on, not with the information that guy's showing me, but in between, in the middle of the process. I don't want to see just before and after. I just want to see what happened. And I want to profit from that information. That's it. So guys, thank you very much for being with me today. This is very important. Let's move on to the next. Before the Q&A, I'd like to thank you for being with me. Next class tomorrow, don't lose it, because I showed you the mistakes. Now, we need to move to the solutions. You need to move to the solutions. I don't see. Huh? Yeah, Q&A, I'm telling you. So tomorrow, next class. Whoever comes tomorrow and the day after, I will give, okay. I'm bad in this. Okay, you come tomorrow, and the day before and the day after tomorrow, I have a special bonus, a special gift for you, okay? So before we go to the Q&As, I'd like to advise you that don't lose tomorrow. And to let me know what you thought of this class, leave your comment here somewhere. My goal is to do my best, and your feedback, this is stuff that I read, but I need to understand now. Okay. My goal is to do my best, and your feedback can help me improve the event experience. Yes, I put it here to remember. Now remember. I want you to give me your feedback. That's what I mean. Please tell me what you're thinking about the class. Of course, I'm going to, maybe I don't have time to change everything, but if I can change something, I can change your experience for tomorrow, okay? And send your Q&A, your questions in the chat, and I'll try to answer them now, okay? Thank you for your presence.